My name is Sadat Rashid. I'm a clinical and an interventional gastroenterologist at Goshen Health. I work in the Department of Gastroenterology and Hepatology in the Digestive Disease Center. I chose a gastroenterology and advanced endoscopy because this offered me an opportunity of both the clinical aspect of treating patients as well as doing a minimal invasive surgeries through endoscopic procedures. Basically, we see mostly adult patients more than age 18, and they vary from all gastrointestinal diseases, including from acid reflux, colon cancer screening, liver disorders, cirrhosis of patients, and gastrointestinal cancers that includes pancreatic, bile duct, liver, colon, esophageal cancers. We pretty much do all the advanced endoscopic procedures and treatment that is available anywhere in the United States. As far as I know, I'm the only one in the area who provides the technique of water immersion colonoscopy and underwater resection of polyps. It can help us in completing difficult colonoscopies with angulated colons and with people who have redundant, or in simple terms we call floppy colons. So I'm happy to have primary care providers refer me patients who have previously had incomplete colonoscopies and or difficult colonoscopies, because this technique can be very useful in helping us complete their colonoscopies. As an interventional endoscopist, I do endoscopic ultrasound, which is basically doing an ultrasound with a specialized endoscope from inside, which can help in both in the diagnostic staging of gastrointestinal cancers, pancreatic cancers, for example, esophageal cancer, rectal cancer, bile duct cancer, and it can help in the diagnosis and staging of that. We also do fine needle biopsy of the tumor at the time if it is not accessible from outside, and it also provides the least invasive way of diagnosing the cancer. I also offer motility testing at Goshen Health, especially for esophageal motility. For this, we do esophageal manometry, as well as we have an additional balloon testing device which is called an EndoFlip, which is a fairly advanced way of checking for any motility abnormalities during an upper endoscopy. I also offer a removal of the polyps using a full thickness resection device in which we can remove previously scarred polyps or even early cancers. I would strongly encourage all our primary care physicians to start colorectal cancer screening at age 45 for all the patients, or earlier based on their family history or their symptoms. I would encourage the primary care provider to talk to their patient regarding differences between stool-based testing and a high quality colonoscopy, and I tell them the differences so that they can understand that a colonoscopy is also a preventive test, because we can remove precancerous polyps before they turn into cancer, while the stool-based testing cannot do that. Adenoma detection rate is a marker of a quality colonoscopy. The higher the adenoma detection rate, the higher the quality of a colonoscopist. On average, the ADR rate for females is around 25%. For males, it should be around 30%. We are proud to say that at Goshen Gastroenterology, we have a very high adenoma detection rate of more than 50%. I also do ERCP, which is an endoscopic retrograde cholangiopancreatography. Post-ERCP pancreatitis risk is around 5% or more on an average in US, and I have an post-ERCP pancreatitis risk which is less than 1%. Patients have a very low risk and they can be discharged the same day and stuff without having any additional days or any other further complications to deal with. Goshen Health offers that patient an opportunity to get a one-stop treatment, whatever is needed to take care of that patient.